Let's take a look at the answers to the warm-up review. First question, how does a drug's dose-response curve change with the addition of a competitive antagonist as compared to the addition of a non-competitive antagonist? So a competitive antagonist shifts the dose-response curve to the right, which decreases the potency. A non-competitive antagonist will shift the curve down, so efficacy is decreased, but potency doesn't change. Next, what are the clinical uses for each of the following sympathomimetics? So dopamine is used to treat shock. Clonidine is used to treat hypertension. It's a sympathomimetic in that it is an alpha-2 agonist, although this actually decreases norepinephrine release. Amphetamines have lots of different uses and can be used to treat ADHD. They can be used for weight loss and obesity. And they're also used for narcolepsy. Terbutaline is used for asthma patients. It can also be given for tocolysis to stop uterine contractions. And then epinephrine is used primarily for anaphylactic shock. And that's it for this warm-up. Let's move on to the lecture.
Hello everyone, and welcome to the Step 1 Derm lectures. These next two lectures will start with some derm anatomy, maybe a little physiology, and then we'll move into pathology. Well, really a list of conditions, and the lecture may feel a little choppy, but don't worry about it. We're going to hit the high-yield things and then move on. Okay, so diving in. Let's go through the layers of the epidermis, then talk about cell junctions, and then we'll cover the first half of derm pathology. Okay, first, what are the different layers of the epidermis? There's the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. And the mnemonic we like using now is, come, let's get sunburned, for corneum, lucidum, granulosum, spinosum, and basale. These are the epidermis layers. One kind of interesting thing about the epidermis is that it doesn't have any blood vessels. The epidermis gets nutrition by diffusion. And the other thing to mention here is that the stratum lucidum is only present on the palms and the soles. So remember, stratum lucidum, palms, and soles. Then underneath the epidermis is the dermis. And where do blood vessels reside? These are in the dermis. And that is all we're going to say about epidermis and dermis. So moving on to epithelial cell junctions. These are at least a 3-star topic and definitely important for you to know for step 1. And there are different ways that cells adhere to one another depending on the cell type. So the zona occludens, or tight junction, this is where two cell membranes join together really tightly just beneath the apical surfaces and form a pretty much impermeable barrier between the cells. So this prevents diffusion across the paracellular space, or in between the cells. And though many proteins compose the tight junctions, the ones you want to remember are claudins and occludins. Claudins and occludins. The zona adherens, or intermediate junction, are located more basally than tight junctions. And this is a cell junction whose cytoplasmic face is linked to the actin cytoskeleton. So this junction serves as a bridge connecting the actin cytoskeleton of neighboring cells through direct interaction. And the molecules I want to associate with the zona adherens are the cadherins, which are calcium-dependent adhesion molecules. The macula adherens, or desmosome, not to be confused with the zona adherens we just discussed, is a small, discrete site of attachment. So desmosomes help to resist shearing forces and are found in simple and stratified squamous epithelium. And they're also found in muscle tissue where they bind muscle cells to one another. A primary adhesion protein here is desmogliin, so desmogliin with desmosome. Antibodies to this particular junction would be anti-desmosome and anti-desmogliin, which is what we see in the disease pemphigus vulgaris, which we'll talk about in the next lecture. Gap junctions allow adjacent cells to communicate for electric and metabolic functions. So what type of cell would you think would have a gap junction? Well, the cardiac cells have gap junctions. That's how your myocytes communicate electrical signals through the SA node, bundle of His, and Purkinje system. And in between the myocytes, there are gap junctions. Then connecting the epithelial cell to the basement membrane is the hemidesmosome, half a desmosome. Desmosomes connect cells to each other, but a hemidesmosome connects to the basement membrane. So one way you can remember this is hemidesmosome is a longer word, so it settles down to the bottom, to the basement membrane. Anyway, if there are antibodies against the hemidesmosomes, then you see the disease bullous pemphigoid. And again, we're going to cover that in the next video. The hemidesmosomes have integrins in them. Okay, melanocytes. Melanocytes are melanin-producing cells located in the stratum basale, the bottom layer of the epidermis. They're responsible for skin color, eye color, and hair color, and they originate from neural crest cells. Okay, we're going to move into some pathology now. And derm can be a little tough, and recognizing some of these may take a bit of repetition. So this may be a section that you need to watch more than once to remember all of it. We're starting with atopic dermatitis, also known as eczema. And some people associate it with seasonal allergies or allergic exposures like food or environmental. And it's seen more often in people with asthma and allergic rhinitis. It is very pruritic. In fact, sometimes people call it the itch that rashes, as in eczema is a pruritic area and people scratch it, which causes a worsening rash, and then it becomes even more itchy. It's a vicious cycle. Patients commonly get atopic dermatitis on skin flexures. This is like the antecubital fossa and behind the knees, and it tends to worsen during the drier months of the year, like in the winter. And you may also see this worsen in babies whose parents bathe them every day, because bathing actually dries out the skin by removing some of those natural oils. So let's talk about some of the ways you can treat atopic dermatitis. So in the study guide, how do we treat it? There are several goals: eliminating exacerbating factors like the frequent bathing, for example, then restoring the skin barrier and hydration, and then adding medications if needed for inflammation. So for hydration, you could recommend switching to a moisturizing soap or just soap less often, or adding an emollient. And then for mild cases, medical treatment would start with intermittent topical steroids for flare-ups, and many times this is all patients need. Then you could also give a topical calcineurin inhibitor like tacrolimus or pimecrolimus if the topical steroids aren't cutting it. Antihistamines can be helpful to prevent the itching, and you may need to give antibiotics if a secondary infection of the skin develops due to this scratching. Leukotriene inhibitors may provide some support for patients who also have asthma or allergic rhinitis, and then UV light therapy can help some. These lesions tend to improve in the summer and worsen in the winter for that reason. And then when it gets really bad, systemic steroids can be used temporarily to control major flare-ups, and for even more refractory cases, if all those things are not helping, especially in an adult patient with severe atopic dermatitis, you could consider systemic immunosuppressants like methotrexate, cyclosporin, or azathioprine. But these drugs are really last resort, and those patients would need to be under the care of a dermatologist or an allergist. Okay, verrucae. These are warts, soft, tan-colored, cauliflower-like lesions. Verruca vulgaris is the common wart, which can be anywhere but commonly occurs on the hands. And then there are plantar warts, or Verruca plantaris. Both are caused by human papillomavirus. The common warts are most often caused by HPV types 2 and 4. And there are several treatments for warts, although in immunocompetent people, these also will resolve without treatment most of the time. If treatment's necessary, salicylic acid, which is over-the-counter, can be applied topically, or cryotherapy with liquid nitrogen can be applied in the office setting. And then there are a whole slew of other treatments that can be tried for refractory lesions, like intralesional bleomycin, imiquimod, or surgery, but these are probably not as high yield for your exam. Okay, melanocytic nevus. This is a common mole. These skin lesions are composed of nevus cells, which are a type of melanocyte. They are benign. The majority of moles will appear during the first 2 decades of a person's life and are related to family history, but also sun exposure. Congenital moles, if they're large or giant, have a higher risk of becoming melanoma. Allergic contact dermatitis. You'll see this in the immunology section as well. So this is a T-cell mediated delayed type hypersensitivity reaction, a type 4 hypersensitivity reaction. This is like nickel allergy or poison ivy allergy. The lesions occur in skin areas that come into contact with the allergen. So with poison ivy, you may see linear patterns where the plant rubbed up against the skin. So if a question describes a very pruritic linear rash, think of allergic contact dermatitis from poison ivy. Okay, let's talk about acne, which is high yield for step 1. So you all know what acne looks like. You've probably experienced it yourself. It's characterized by areas of skin with seborrhea, comedones, papules, nodules, and even scarring. Pathophysiology. Well, there are 4 components to acne. There's hyperkeratosis, too much keratin, sebum overproduction, Propionibacterium acnes proliferation, and inflammation. So let's talk about the drugs that we use to treat acne. They're going to address one or multiple of these 4 areas. So let's talk about hyperkeratosis first. What's going to inhibit that? Well, as it turns out, this is vitamin A analogs like retinoic acid. And there are a number of topical retinoids like tretinoin or oral systemic retinoids like isotretinoin. Then you can also use topical salicylic acid or hormonal therapies like oral contraceptive pills, which can help with the hyperkeratosis as well. Sebum overproduction. So what's going to address that? Isotretinoin will also address sebum overproduction, and then hormonal therapies can help here as well. And in addition to oral contraceptives, you might also think about spironolactone. Spironolactone is a potassium-sparing diuretic, but it also has anti-androgen capabilities that can help with the acne. Then the next one, Propionibacterium acnes proliferation. What is going to inhibit that? Well, antiseptics like benzoyl peroxide, which is a first-line treatment for acne, or topical or oral antibiotics if necessary. And which antibiotics can you use? Well, topical clindamycin or erythromycin are helpful, or orally you could give tetracycline, doxycycline, or minocycline. And then the last area is inflammation, so this is more of the same. Oral isotretinoin or topical retinoids, and then the tetracycline antibiotics actually have an anti-inflammatory effect for acne in addition to the antibacterial effect. So the treatment strategy for acne is actually a bit complicated with lots of considerations for types and locations of lesions, and we're not going to cover any more of that here. Psoriasis is one that you definitely want to know. Psoriasis historically had been described as an overproduction of new skin cells with cause uncertain, although now it's believed to be more of an immune-mediated disease caused by activated T cells and dendritic cells. So what you see are papules and plaques with silvery scaling. It's one of the few things that causes a silvery scale. So if you see that on the test, think about psoriasis. Patients will very commonly have this on the knees and elbows. And if you look at the skin microscopically, you notice an increase in the stratum spinosum and a decrease in the stratum granulosum. And sometimes you'll see psoriasis associated with something called parakeratosis. This is where you see nuclei retained in the stratum corneum. So that's definitely a term you also want to associate with psoriasis. If you see parakeratotic scaling, think about psoriasis. Auspitz sign is when you have bleeding spots when the silvery scales are scraped off. Psoriasis can also be associated with pitting of the nails. The pitting will look like little divots in the nail. And then about a third of patients will also develop psoriatic arthritis. So how do you treat psoriasis? Well, we could spend all day talking about that, but here are some highlights. So the first line is non-pharmacologic. You want to moisturize the skin well with moisturizers and emollients. And then there are several topical treatments like steroids, tar-containing creams, vitamin D analogs, and retinoids. All of these attempt to normalize skin cell production and reduce inflammation. Phototherapy has been used with some success, and then there are systemic treatments like methotrexate, cyclosporin, retinoids, and nowadays the biologic response-modifying agents like adalimumab, etanercept, infliximab, and 5 or 6 others are really commonly used and can clear even severe plaque psoriasis. So, of course, the choice of treatment has to do with the type of psoriasis and severity, among other considerations. All right, that's it for the lecture. Now it's time for the end of session quiz. List the layers of the epidermis: stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum basale. Which structure connects epithelial cells to the basement membrane? Hemidesmosomes. And what are 4 primary causes of acne? Hyperkeratosis, sebum overproduction, Propionibacterium acnes proliferation, and inflammation. And then which skin disorder matches each of the following statements? Pruritus associated with asthma is atopic dermatitis, also known as eczema. Allergy to nickel is contact dermatitis, which is a type 4 hypersensitivity. Parakeratotic scaling is seen with psoriasis, and caused by HPV types 2 and 4 are common warts. All right, that's it for Rheum Derm 7.